second year emergency medicine resident over at San Antonio University Health. And today I'm going to be giving a presentation on Diltiazem, the setting of supraventricular tachycardia. So supraventricular tachycardia, also known as SVT, but also known as paroxysmal SVT, is a condition where the heart beats a little bit too quickly than it should. It's caused by like a error in the conduction system of the heart. So starting from the SA node and then working down to the AB node uh, and through the rest of the Purkinje fibers, bundle of His. It mostly affects the atria of the heart. So kind of what we're seeing over here is the SA node and the AV node. The whole right atria, that's kind of where the system starts to kind of take effect. So with SVT, your heart beats a little bit too early. So where those issues kind of arise is when your heart beats too early, you don't have adequate filling of your ventricles, so you have like decreased cardiac output. And where issues can arise is when people can develop chest pain, they can get syncope, shortness of breath, dyspnea, those kind of symptoms. So as we know, like a normal heart rate is about 60 to 100 beats per minute. But for SVT, it's going to be ranging anywhere from like 150 to about 220 beats per minute. So here's a little bit of a better picture for kind of what we're talking about. So you can see on the bottom there's like that rhythm strip. You can see the P waves, QRS complexes, and T waves pretty clearly. Everything seems like intervals are appropriate, and there's no ST or T wave changes. This is like a normal sinus rhythm show. So this where the how the process is supposed to work is that you'll have a electrical system, the pacemaker, who kind of sets the whole rhythm of the heart. That's located up in the SA node. Your SA node is going to send signals down through your atria to the AV node, and from the AV node it goes down to the bundle of His and throughout the Purkinje fibers, where a lot of the ventricular contraction takes place, and that's how our heart works. But with SVT, what issues arise is when that electrical signal from the SA node somehow or some way is not able to progress through the AV node or to the bundle of His, and so it kind of just stays up here in the right atria, like a little re-entrant rhythm. And so that's where that little early beat of that SVT that we saw on the previous slide kind of comes from, is that your heart is kind of beating too early due to that electrical system not be able to progress forward. So there's several types of SVT. Uh, Probably heard of like aberrant or atrioventricular nodal reentrant tachycardia. That's like the most common. That's kind of what we think about when we think of a typical SVT. There's also atrioventricular reciprocal tachycardia. That's more common like in adolescents or teens or younger adults. Then there's just atrial tachycardia, and that doesn't involve the AV node at all. It's more of an issue with the actual like atrial muscle of the heart itself. So here's a little picture to show kind of like the full cardiac cycle. So filling and then pumping out through the ventricles and throughout the rest of the system. It all depends on the kind of initial electrical signal sent by the SA node, going down the AV node, bundle of His, throughout the Purkinje fibers and to the ventricle to have more of a full cardiac cycle, good rhythm, good everything seems pretty a-okay here. So here's some EKGs, for example. So kind of what we saw in the previous picture. Everything seems to be appropriate. I see P waves, I see QRS, I see T waves. All the intervals seem appropriate. No like ST or T wave changes that I'm really appreciating here. So this seems to be more of like a normal sinus rhythm EKG. And now here's an EKG of SVT. You can see how things are a little bit more of a faster pace. So I would say this is definitely more of a in the sinus tachy of areas. But as I try to appreciate the rhythm, it's kind of more difficult to appreciate the P waves. And so this is kind of how I kind of differentiate like an SVT or an AFib or just sinus tach from each other is being to identify if there are P waves or not. So you can kind of appreciate a little bit of P wave right there, but most of this is going to be an example of SVT. So kind of what we were talking about earlier, some symptoms that you're gonna have associated with SVT. I kind of just think about the whole like pathophys of the whole area. So we lead to improper filling of the heart due to like rhythm issues. So that's going to lead to a lot of chest pain or palpitations because you're not able to adequately fill the heart, and during diastole, that's when the coronaries are kind of perfused. So you're not able to fully adequately fill the heart. You're going to develop chest pain and palpitations, and the palpitations are to be expected because your rhythm is a little bit off than normally it would be. Other symptoms could be your syncope that we were discussing. That's a pretty big concern that we have. Dizziness or lightheadedness, shortness of breath or dyspnea, diaphoresis, all these pretty similar symptoms leading to overall or stemming from decreased cardiac output, mostly leading to your brain and your heart and your lungs. So how do we really handle this? So like an unstable patient, so we're going to define that as SVP less than 90. This is someone who is considered unstable with SVT. So I would go ahead and do a IV bolus, so a little bit of IV fluids, and some fentanyl for pain control. You can either do IV if you have IV access or IM. Oh, the first step you're going to do is synchronized cardioversion. So placing the cardiac pads correctly, either on the interior posterior or anterior lateral positions, in order to provide a good arc for the electricity as well. For stable management, so this is going to be SBP greater than 90. I like to use the vagal maneuver, and I can show you a video about how that works. Um, but if it's unsuccessful, then I reattempt with a reverse valve cycle. So that includes like blowing on the syringe and lifting the patient's up, his legs up to the ceiling, and that produces like a decrease in vagal tone, and you're able to kind of reset the heart back into rhythm. But if that doesn't work, you can always use medications. So this all is going to involve doing that vagal reflex to kind of reset the AV node. So if you're not able to do that with the maneuver, then you can use adenosine. So adenosine is going to be first attempt is going to be 6 milligrams IV. And if that doesn't work, then the second attempt is going to be the 12 milligrams IV. Next up will be like your calcium channel blocker, so Diltiazem, verapamil. For verapamil, dose is going to be about 5 to 10 milligrams. But for Diltiazem, that's the medication we're going to be talking about today. That's for the first attempt will be about 0.25 mg per kg IV, or it will be for the second attempt 0.35 mg per kg per IV. And so that's going to be our main focus for today, is talking about the Diltiazem in the setting of SVT. So here's a video that you can check out. And with Diltiazem, it's a class 4 antiarrhythmic, so that meaning it's a calcium channel blocker. So it's going to act at the calcium channel of the heart muscle to kind of reset that AV node and kind of give it time to pause. So why do we like it over adenosine? So adenosine is kind of like turning the heart on and off again. It's overall going to come chest pain and a pending sense of doom, which we want to generally try to avoid. It's also less likely to relapse with SVT like adenosine is. So a big caution is to be cautious with people who have like pre-active excitation syndromes, anything like double PW, shortened PR, delta wave, AFib, because you can actually send someone into a VFib if they were to have like atrial fibrillation or Wolff-Parkinson White and you give them a Diltiazem. Thank you.